Well, this is super exciting stuff here. I noticed in the lectures this morning, they talked a little bit about personal injury cases, car accident cases. That's really what we're going to be talking about here. So we've got those two subject matters, permanent impairment ratings and personal injury reports, because certainly not all car accident cases lead to a permanent injury rating. However, you need to take the same steps in preparing information so that the patient gets a fair settlement. Now, there are over 42 different studies that have been published since the 1960s that talk about prognosis, how a person who is in a car accident case or a whiplash case is going to have long-term chronic issues. 50% of all patients who are in an automobile accident is going to have a long-term problem. So today we're going to talk about what you can do to document that, to give a fair adjudication for them. So I do need to give you just a little bit of a disclaimer notice. I do own a company that does drawings for AOMSI reports. So just as a conflict of interest, I'm disclosing that. So what we're going to cover today is 4 different things: the elements of a PI report, the AMA guides and how they assess a PI report. We're going to go over the whiplash injury findings, what you're going to look for, and the AOMSI methods and what your attorney expects. And just so you know, all the slides that I have up here, except for a couple videos and the report itself, are all in the notes. So there's over 100 of them. There's 100 PDF slides you have available in your notes. So you're not going to miss anything. So let's talk about Iowa traffic fatalities. So just looked up all this data here a couple days ago. And in 2025, we had a historic low, 260 deaths from auto injuries. The Iowa crash volume, how many car accidents were reported? We all know there's more than those that are reported. 267,000 crashes over the last, from 2019 to 2023. So we're averaging around 53,000 auto collisions in Iowa annually. 90% of those collisions, the reason for it, the cause, was human error, ranging from speeding, distraction, fatigue, impaired driving. And so far in the first quarter of 2026, the rates are higher. So it's worse than last year. Last year was actually one of the best years for fewer accidents. So let's look across the United States. There's over 6 million car crashes reported across the United States. And when you look at the graph, while it has trended down a little bit, the peak was in 93, 95 in that area, it's still significant. It's still 2.4 million people reported an injury, a whiplash injury, out of those 6 million car crashes. There was 39,000 deaths. So when we look at whiplash, a lot of people, myself included, used to think the term whiplash, ooh, that sounds kind of, litigious, right? Whiplash is inside hundreds and hundreds of research studies all over NIH. It is a term used to describe a mechanism of injury. Whiplash is not a diagnosis. Whiplash is a mechanism of injury. So we need to know about it. And there are thousands of studies that have been published on whiplash. So we need to understand the dynamics, the biomechanical dynamics. How does it impact the structure of the vertebrae, the nerves? And think about this for a minute. How do you do a study on a live human being on a microscopic level to determine axon and facet capsular nerve damage? Can't be done. Okay, I mean, what are you going to do? You're going to go in and take a biopsy of their facet capsule and then put it under a microscope? So all of the study and the research is most often done on cadavers. Some have been done on animals. The cadaver research that Punjabi and White. All of us in college, you remember Punjabi and White? Everybody kept saying it. So this is their book, Clinical Biomechanics of the Spine. Punjabi and White. You know how much this book cost, by the way? I bought it used for $327 on Amazon. Brand new, I think they're selling it for $400. It's crazy. But why is that book so important? The AMA relied heavily on that one book right there to come up with their impairment ratings for cervical spine AOMSI, Alteration of Motion Segment Integrity, which we'll be getting into today here. So what are some of the most common symptoms in whiplash that people are going to experience? The prior speaker, Ron Faribaugh, in there just told me he was in a car accident 2 weeks ago. He still has ringing in the ear. He's having all kinds of problems, balance, this and that. My point for bringing that up is this laundry list of symptoms has been documented. Just 1 second here. It has been documented in the literature vastly. We often think, oh, it's neck, it's muscle, it's ligament, maybe a radiculopathy. It's far more than that. And the new literature on the psychological impact of whiplash, it's dramatic, the amount of research coming out on it. Cognitive nausea, visual disturbances, dizziness, hypersensitivity, mounds of research on neurological hypersensitivity, which you can't see on an MRI. You can't see on an X-ray. Yet post-cadaveric studies and all this investigation has now proven it without a shadow of a doubt. And we've all heard about scar tissue. So when we grade ligament injuries, grade 2 ligament injuries and grade 3 is complete tear. Grade 2 ligament injury still leads to scar tissues in many cases. So this is a diagram that I had ChatGPT create for me. Took a long time, very frustrating. Anyway, I used actual slides, microscopic slides that they obtained of collagen fibers, torn ligaments that actually happen. And this is one of the main reasons why tissue is weaker, less elastic, and less stable. So we also need to look at the risk factors that leads to the micro tearing and at a grade 3, a full tear. The research shows that when you're driving in a vehicle, if your head was turned looking up at a rear view mirror, for example, let's say you heard the skid marks behind you. So you looked up, then you had whiplash. Having rotation increases the damage and the prognosis is worse. The literature is divided on rear end impacts versus front end impacts. The old literature says rear end impacts definitely cause more harm. Now it's kind of a 50-50 thing. Side impacts adds a different element. If the person is not paying attention and they're looking off to the side and they go into a whiplash injury, just look at the biomechanics yourself. There's spinal rotation, and then you get a hyperextension, hyperflexion, and what we call whiplash-associated disorders dramatically increase. Other significant factors, if you're a female, any human over the age of 35, prognosis gets worse as it goes up. Over age 50, it gets worse, and 65, dramatically worse. Smaller framed females are definitely worse. If you're also have a poor head restraint, and the head restraint is pushed all the way down, if the seat back breaks, all of those things impact the prognosis and the biomechanics. And what about pre-existing components? If someone already had degenerative changes in the spine, they're going to have a poor outcome. If they already had disc thinning, poor outcome. So you need to document what was there. So don't be afraid to document pre-existing findings. So much of us think, oh God, the pre-existing thing, it's going to impact. They're going to try to blame the problem on the pre-existing. The pre-existing leads to a poor prognosis. Document all of it. And then here's the other interesting thing. There was a new meta-analysis. It was just released in 2025. They analyzed over 62 studies. and they showed that the patient who has more pain at onset in that first week, and they're complaining of significant pain, which is why you want to do OATS, outcome assessment surveys, you want to do PROMs, type surveys on your patients. Patients who are rating their pain very high in the beginning, they have shown those people have a poor outcome long term. So on imaging, how many of you can say that you've treated sports injuries and you had a concussion come in, and then out of safety, security, you might order CT depending on the neurological component of the severity, and the CT comes back normal, almost always, okay? It's hard to see a mild traumatic brain injury, a concussion, on a CT or an MRI, because it doesn't show anything, because it's all microscopic. It's the same thing in whiplash injuries. They don't show up on an MRI, unless, of course, a disc rupture resulted and it was super severe. But the majority of whiplash injuries show normal findings on an MRI. So because of that, attorneys on the opposite side of the fence will try to say the MRI was normal. However, the literature talks about this dramatically and says there's still ligament injury. So let's look at this slide here. When we look at the spinal canal, the posterior longitudinal ligament, which is right in front of the spinal cord, it's not on this model, but it's right in front of the spinal cord in the white space. That PLL, you might say, well, if there was a grade 3 tear of the PLL, wouldn't you see a tear on an MRI? And the answer is no. And here's why. An MRI is done laying flat on your back, and even if you did a standing MRI, you're standing still. The tear is less than a millimeter in many cases. It's a singular line. And then you say, well, I have all the slices. If you're lucky, maybe one slice shows some kind of an artifact, but it's not going to be enough to give a definitive diagnosis that there's a tear of the PLL. That is why flexion and extension plain film x-ray views are motion views. Now, if you could do an MRI in flexion, it might show up, but we don't do MRIs in flexion or extension. And therefore, the ligament injury isn't going to show up. Now, obviously, we're going to see disc injuries show up on MRI, or are we? Micro tearing on disc fibers don't show up on an MRI. And the studies now show that significant axonal and microfiber disruption occurs on the disc in a whiplash injury undetected by MRI. And you might say, well, how do they know this? They've done it on animal studies, cadaveric studies. People have donated their bodies to science. And if you wonder, well, where are all these studies at, Steve? I'm not here to promote my book because my book's not published yet, but it's 1,028 pages, hundreds of research studies summarized on all of these subjects. So when I keep saying research, hey, what are they? I'll give them all to you because I have a special surprise for y'all if you're in the room later and you're not asleep. Okay. So we all know the gold standard of the Davis series. Now, there's a debate, should you take oblique views if there's no radiculopathy or no radiating pain to the trapezius muscle? I'll give you that. Then you might take a 5-view series. But typically, we're taking a 7-view Davis series in the cervical spine. So when we look at the cervical spine, on plain film radiography, you can actually detect an indication of stenosis, spinal canal stenosis. If you're doing the anterior vertebral line, the posterior vertebral line, and the spinal laminar line. So between the spinal laminar line and the posterior vertebral line, if there's a difference or disruption in that area, it might tell you to go get an MRI, to go look at it, because MRI is still the best for looking at stenosis, but plain film radiography can give you an indication. Now, there's a whole host of other measurements and biomechanical analysis that we all can do on plain film radiography. Everything from spondylolisthesis, compression fractures, disc thinning, a whole host of analysis biomechanically, not just in PI cases, but in all of our patient cases. And flexion extension adds even more. So stenosis on MRI is easily visible with disc bulging, but sometimes vertebral anterolisthesis or retrolisthesis can indicate that we actually have a problem, indicating ligament injury. And besides those of you who are Gonstead practitioners on the far right there, cervical lordosis, upper cervical technique, all these other kinds of reasons for doing biomechanical line measurements on X-ray. So what actually happens in an anterolisthesis from trauma? So when we go into hyperflexion, we're looking at a PLL injury. And if we go into hyperextension, we're looking at an ALL injury. But we can't see it on an MRI, and you can't actually see it on an X-ray. But here's what the AMA says. The AMA Guides to the Evaluation of Permanent Impairment have gone on to state that there is ligament damage. There is a mobility problem when measurements for AOMSI, alteration of motion segment integrity, is present on plain film X-ray. So I was certified in the 4th edition. This is the 3rd edition. This is the 4th edition. Look how thin these are. These are the textbooks back in the 90s. Then the 5th edition came out, which is kind of the gold standard here. Okay, it got a lot thicker. It got more complicated. The 6th edition came out in 2008. It's about as thick, just a little thinner. And now a new one came out in December of 2024. It's called the 6th edition 2024. And it's not in a book. It's digital only availability. I will tell you, it's the easiest of these 3. It's the easiest impairment rating of those 3. Now, we'll talk about these editions in a little bit here. Because if you're going to provide an impairment rating, the only way you can give an impairment rating is through the AMA guides. There is no other accepted format for providing an impairment rating. And if you give an impairment rating, it's permanent. You can't give a partial impairment rating. You can't give a temporary impairment rating. There's no such thing. The AMA says so right in all their books. An impairment rating is permanent, or there isn't one. Now, let's not confuse impairment ratings with disability ratings. We'll talk about that in a little bit here. So these books that I'm sharing with you, am I telling you if you want to do impairment ratings, you should go out and buy that book? Question?
You said the AMA impairment rating. What about the Canadian version, the Quebec one that was heavily researched?
Yeah, I'll go over that. So the Quebec Task Force that he's talking about, which was established in the 90s, is deficient because it is focused on the acute care. It is not a long-term prognosis at all. They don't even address impairment, okay? So if you're gonna quote QTF, Quebec Task Force, I caution you if it's a person who has ongoing residuals. You with me? It's good for acute whiplash cases. So the digital version of the 6th edition of the AMA guides, it's an annual subscription. They're in it for the money. Come on, okay. Here's the thing. Here's what you get though. So if you don't own any of these textbooks here, if you sign up for the digital version, you get all of them. So they have the 5th edition, the 6th, the 6th 2024, the 4th edition. You've got all the past versions. So you're going to have to make a decision. Do you want to use the 5th edition? Do you want to use the 6th? Or do you want to use the 6th 2024? Because you have the right to choose whichever one here in the state of Iowa. So what's the purpose of the AMA guides? So the AMA guides isn't just for documenting in your records. The AMA guides is a set of rules for evaluating a person's health status. So the end result is a number. The whole focus of the AMA guides is to give a number. And what's the purpose of the number? For the court system to give compensation to an injured person. The AMA guides isn't, watering down what's their purpose. Their purpose is to give money adjudication to a patient. It's the whole purpose of an impairment rating. Otherwise, why are we wasting time doing a rating on somebody if we're not going to use it for settling a case? Now, we have personal injury cases and we have work comp cases. Is the guides designed for work comp cases? It's a 50-50 answer. The answer is yes, but work comp cases don't rely 100% on the impairment rating alone. The impairment rating is a part of a disability rating. We'll cover that more later. So there's a concept called whole person impairment, or whole person. So if you were 100% impaired, would you be in this room? No. You know why? Because you'd be in a coffin. If you're 100% impaired, you're dead. Okay? So none of your patients will ever have a 100% impairment unless you're going to their funeral. They use a set of combined values. So you might say, wait a minute, if that's the case, are you telling me, Steve, if I give somebody a 25 to 28% impairment, according to the 5th edition, just of the cervical spine, I could think of all kinds of health problems, kidney problems, heart problems, neurological problems, Parkinson's, all of these things could add even more impairment to a person's health. True. That's why they have combined values. So it's not an addition game. You don't start adding numbers. You use combined values. And amazingly, nobody can ever get above 100% or 99%. Okay? It can't happen. You can try it. At the end of the book, we'll get to it here. But let's talk about what edition should you use. So this has it in their law to use the 4th edition. And they never updated the law. Most states have, well, I shouldn't say most, about 25 states have the 5th edition listed, and about 13 to 15 states have the 6th edition, and some states don't address it in their code, in their rules. So let's talk about the use in Iowa. So in Iowa, for workers' compensation cases, our code says 5th edition. It's in the Iowa code. They go by the 5th edition, the Green Book. Okay? This is the book if you're doing work comp, you have to use the 5th edition. Now, what about car accidents? There is no law in any state that I'm aware of, definitely not in Iowa, on what you can use. So it's up to you, the doctor. Now, I've testified in court over 32 times. I've done over 90 depositions. I have never been questioned, why did you do the 5th and not the 6th? Now, if you choose the 5th, now some of you are saying, well, Steve, why wouldn't we pick the latest edition? I agree. I think we should. But do you know why? Your lawyer friends are going to say, no, do the 5th. And why the 5th? Because the 5th is more generous to the patient by far with what I'm going to show you today. Far more generous. Well, it's easier to use than the 6th, but not easier than the new 6th 2024. The 6th 2024, in 1 hour, you're all trained in it. You go right down the line and just do a little reading and you pick it. There's no combining unless you've got lumbar problems as well. But today I'm focusing on the cervical spine because we only got 1 hour and 40 minutes and there's no way I can certify you in all parts of the spine and the whole body here. So the Iowa Code specifically states, this is straight out of the Iowa Code here, Code 876. they go on and they state that the primary impairment determination is the 5th edition. Now, who can do impairment ratings? Can chiropractors do impairment ratings? It says so right in the AMA guides. The 5th and 6th edition state chiropractic doctors can do impairment ratings. Now, you know who they left out? Physical therapists. Now, physical therapists, I know for a fact, do impairment ratings, but according to the AMA guides, the only people who can do them are MDs, DOs, and DCs. Okay? Now, I'm sharing this because I just want to make us feel better. The 6th edition, 2024, it just happens to be, one of the editors of the book happens to be a chiropractor. So that should make us feel a little bit better. He's an MD DC. He's out of Canada, but he's one of the lead editors of the 6th edition, 2024. I'm sharing that with you because some of you in a deposition are going to get grilled on cross-examination. How can you do an impairment rating? You're not an MD. That's the American Medical Association. You're going to refer them to that prior slide, and for those of you who came in later, all the slides are available through the ICS code there, and it tells you exactly where that says it in the book, so you don't have to thumb through it all. But it says it right in the book. You direct them to that, and you say, and one of the lead editors was a chiropractor. Help shut them up real quick. I've done that before. So let's talk about the difference between impairment and disability. So impairment is specifically the loss of use or a change in a body part or organ or body function. It's a medical finding. It's a finding. It's a number. It's a percentage that gets applied to them. Disability, on the other hand, is a descriptive disability where it'll include an impairment rating. It can, because think about this. Let's use the piano player. I'm a pianist, and my right hand got chopped off in an accident. I don't even have a right hand. So the impairment rating for this person, is he impaired? He is. So the impairment for this is going to be less than 20%. But this person is 100% disabled. They're no longer a pianist. They can't function. 100% disability, 20% impairment. You get the difference? Disability has to do with not just job, it does have to do with social, but disability, you're assessing their ability to perform activities. Can they do the activity? An impairment rating, we're not assessing activities. You are to some degree, you're assessing activities of daily living that can add a percentage to it, but for the most part, you're assessing what's the range or what is neurological loss or a finding on that spine. So understand that an impairment evaluation is always designed to determine a permanent impairment. So don't ever get caught up in a report saying, well, they have a partial impairment. There's no such thing, okay? Now, partial disability, that does exist. You might write a handicapped validation for 90 days because they're temporarily disabled because they're recovering from knee surgery and they have some disability, they can't do this or that. That's a disability, it's not an impairment, unless that surgery didn't work and they're permanently have loss of knee function. So it's impairment is function loss, a percentage is a rating, and an independent medical evaluation. It can only be independent, and you don't have to be an independent, an IME, but an independent means you're not the treating doctor. You as the treating doctor are certainly allowed to do an impairment rating or a disability evaluation. The opposing attorney might claim you're biased because you're trying to help your patient. And I just share with you, don't try to help your patients. Apply the rules the way they are, and that's what it is. Even when we look at disability, how many of you had a patient come in, now I'm not talking impairment, I'm talking disability here. A patient comes in and says, Doc, I need a handicap sticker. Give me a handicap sticker. And you're kind of like, what the you don't need a handicap sticker. And so they have all their reasons and they have this and that. So I might give a 90-day handicap sticker. I've had patients get pissed off at me for giving them a 90-day. They wanted a permanent one. Don't break the rules. Apply your findings. All right.
How about the ones that want so they don't have to wear a seatbelt because their shoulder hurts, they don't want to have to wear a seatbelt.
I'll let you get into that. I don't know. So we're going to introduce a concept to you called MMI, Maximum Medical Improvement. Okay? The legal purpose of an impairment rating is for compensation. So don't feel bad about why you're doing an impairment rating. It's because the person deserves compensation. So make sure, and guys, I'm going to tell you this. I've interviewed so many patients who have problems beyond 2 years. And the two guys I just interviewed, they're both, one's in their 50s, one's in their 60s. The one guy had his car accident 20 years ago, okay? He still has problems to this day. He told me he's had over 12 MRIs since then. So the settlement he got, like 40 grand, he goes, I've spent over 100 grand in future medical bills. I never got a fair settlement. It's pretty catastrophic. And as I said earlier, the research shows half the patients are going to have symptoms beyond 2 years. There are studies that have gone 12 years. There are studies, one study went 20 years, another one went 14 years. A lot of them just went 2 years, showing these statistics. So we have to be aware of that and make sure we document appropriately. Now, when you're going to do a report, there's two kinds of reports. There's a narrative report on the entire case, and then there's an impairment rating report. And I suggest to you to not mesh the two together. Keep the impairment rating report as a separate standalone report, and it becomes a supplemental report to your master narrative report, because your master narrative report is going to describe the car accident. It's going to describe the initial presentation. It's going to describe their response to care. It's going to describe the test. It's going to describe all your objective documentation. An impairment rating, there's only certain things that lead to an impairment rating. And if you mesh it all together, it can get confusing as to what was relied on. Because in an impairment report, you're going to have right at the top, I relied on my exam findings, my clinical history findings, and my advanced testing. That's all the AMA says you need to do, and you're just going to state that. But the details of those don't belong inside the impairment report. So when do we do an impairment rating? Okay, when do we do this? At MMI. And maximum medical improvement is clearly described in the AMA guides. And when is a patient at MMI? It's when they plateau in their recovery. It's when they're no longer going to receive any significant benefit from any future treatment or care. So who makes that determination? The treating provider, you do. Or sometimes an independent medical evaluator will request all the records of all the providers, review through it, and say, it looks like you've plateaued. You're going to the chiropractor here. You're not getting any better here the last 2 months. So now that doesn't mean the patient doesn't deserve palliative care, supportive care for flare-ups and exacerbations. You just document that in your records. So you're going to document the patient is plateauing in their recovery. I'm going to see them periodically every, whatever it is, 4 weeks, 3 weeks, 6 weeks, because that's the amount of time that they start degrading and having flare-ups. So I'm providing supportive care. Stop using the word maintenance care. It's supportive care for this injury, okay? And put that inside of your notes. And then there's no predetermined date when MMI is achieved. Many people say, oh, it's at the 1 year mark. You're at 1 year. You're at MMI. MMI could be at 6 months. For the piano player, The hand got chopped off, had surgery, MMI was 30 days later. It's done. So MMI doesn't have a timestamp on it, but you must have an MMI determination date. What date did you determine MMI was achieved? You do need to document that. And then what did you use? What was your basis? What was your medical decision making to determine when, why you did it on that date? Well, I did on that date. They came in for an exam. I looked at my last records. I had been tapering off the last 2 months, and I feel they've plateaued over the last 2-3 months, because it's hard for you to say, well, I think they're going to start plateauing right now. Wait 3 months to prove, yes, see, they plateaued. I saw them 3 times in the last 3 months. They, in fact, have plateaued. I tried to stretch them out to 6 weeks, but they came back in at the 4-week mark, and it seems like that's the most they can go because they have chronic symptoms. So now I'm going to do the impairment rating now. Now, we talked about doing flexion extension x-rays to do an AOMSI analysis. When you take x-rays, flexion extension, can you do an AOMSI analysis in that first week of care? Certainly you can do it, but let's say you found out that they met the threshold for an impairment rating on AOMSI. You can't say they have an impairment because they haven't undergone treatment and they're not at MMI. Now, I'm sharing this with you because I've seen doctors out there use the initial x-rays to determine AOMSI 2 years later when they are at MMI, or a year later when they're at MMI, and now they do their impairment rating report, but they use the x-rays from when they first came in the clinic. Mistake. On the date you determine they're at MMI, you don't need it to repeat the Davis series. Take flexion extension x-rays. Take a neutral, a flexion extension x-ray, those 3 x-rays. You really only need the flexion extension. I like to take the neutral because I want to prove flexion is different than neutral. Because in some patients, their flexion view kind of looks like it's neutral because they can't bend it any farther. So I take those 3 views at MMI, and then your impairment rating report to determine AOMSI is on those x-rays. Now, you might document and do the analysis up front to know what you're dealing with. That's fine, but you're not using that in your final impairment report. Now, what if you're at MMI and you determine they have a significant anterolisthesis? They have AOMSI, alteration of motion segment integrity. And one of the solutions is surgery. After all, it says right in the AMA guides and in a lot of treatment, a completely torn cervical spine ligament, the ALL, the PLL, the patient is a candidate for spinal fusion, or like this one, putting some screws in because it's unstable. Now, it doesn't have to be unstable with special strengthening exercises with chiropractic care on the level below or above. But if a patient declines treatment, can they say they're at MMI? The answer is yes. The patient is allowed to decline any kind of treatment, and the AMA guides clearly states this and states that you need to document this because the attorney is going to say, well, surgery is an option and they haven't exhausted all of their options to get better. Question?
Should you state that they are at MMI for your conservative management that you're able to provide?
The question was, should we state that they are at MMI for your conservative management? No. You have discussed with them or you referred them out for a surgical consult and the neurosurgeon says, hey, I'm 50-50 on this surgery. It might help. It's up to you. Let's say the surgeon says, I'm 90% certain this is going to help. I'm 100% certain this is going to help. But the patient is afraid of screws in their spine. The patient has heard horror stories of people not responding to surgery, and the patient just says, I don't want anybody cutting on my neck. So I would say to you, you should refer out for a surgical consult, and regardless of what the surgeon's opinion is, if the patient states, I don't want to do what the surgeon said, you document that, and you want to document the other options. It might be a nerve ablation. There might be some other kind of surgery, or there might be opioids for the pain, and the patient declines those things. Document that and just say, the patient, other options such as this, this, and this has been discussed. The patient did not want to pursue those options. Therefore, looking at their current status, plateau in recovery, does not appear they're going to get any better. They are now at MMI. So I'm just going to briefly go over apportionment here because I got a lot of stuff to cover. The only reason I'm bringing it up, there's a group out there who talks about apportionment, and they're telling you wrong things. Are you allowed to apportion an impairment rating? The answer is yes, but it's on pre-existing conditions. So let's take this for an example. Let's say somebody has a 25%, according to the AMA guides, AOMSI, they're allowed to be given a 25% impairment rating. But let's say they didn't quite meet the threshold for the 25%. Let's say they were 95% there. God, he was just 1 millimeter away. He was just a half a millimeter away from getting the 25% impairment rating. Because of that, I'm going to give him a 15% impairment rating. I've decided to pull that out of my ass, and I'm going to give a 15% impairment rating. You cannot do that. The AMA guides does not allow that. Now, let's say they had pre-existing conditions. Let's say they had a prior car accident and they had an impairment rating of 5%. And then now they come in to see you of the same area, same region, cervical spine. And let's say yours is 25%. Then you would subtract the 5% from your 25 and you apportioned the impairment rating. On the other hand, let's say they had a whole bunch of other difficulties of pre-existing problems. Could you bring the percentage down? Yes, you can apportion and bring the percentage down. I've only had to do that a few times. But what I'm saying to you is you can't go up. You can't grant, if they didn't even qualify for the impairment rating in that region, you can't give them one if they never met the original threshold for it. So the other thing you have to be careful of is, what if the prior impairment rating was 15 years ago in the 5th edition and now you're using the 6th? You've got to be careful and try to use the same edition. So this chart you see, this is that combined values chart that I was talking about. So let's do an example here. Let's say we have a cervical spine 17% impairment, and we have a pre-existing 4% impairment. So then I apportion it and I give this person a 13% impairment. Now, let's do an example of 2 body regions. Let's say a person has a 17% impairment on the neck and they have a 4% impairment on the low back. Do we just add the numbers together according to the AMA guide, 17 plus 4? No. Whenever there's regional impairment, you go to the combined values chart. So on the far left, you start there first and you go with the highest number. So we have a 17% impairment in the neck. We have a 4% impairment in the low back. We go down 17 on the vertical column, and then we go over 4 on the horizontal column, go up. What's the number come to? The number comes to 20, not 21%. That's how, in my earlier example that I was talking to you about, that nobody can ever get above 100%. The chart magically works out. It's impossible, adding up all these impairments. So, good, that was my halfway mark. So now we're going to start getting into AOMSI here. Question?
How if the impairment was more than 2 regions?
Then you continue combining. Okay, so the question was, what if they have 5 impairment ratings? That happens all the time. You might have a neurological impairment, you might have a knee impairment, a low back impairment, a neck impairment, and you assess the regional impairment rating. Now in the book, when they use the phrase whole person impairment, you're going to use the combined values chart when you get to whole person impairments. So what I would do, you go with the highest numbers first. So you always use the highest number on the left on the vertical column. You add the two together, 17.4, that's a 20. Now 20 is the highest. So now I go back over here, I go down 20. Let's say the knee impairment was, you always do the highest numbers. Because I use 4 as the example, now I'm going to pick a 2. So now I go a 20 and a 2. You get me? You always do the highest numbers first. Yeah. And so you're combining impairment from regions. So here's what we want to get to. We want to get to creating a measurement that's easy for us as chiropractors to do off of x-ray. So AOMSI, alteration of motion segment integrity. Here's what hasn't changed in all of these additions that I've shown you. How you calculate AOMSI. There's been tons of changes. Like in the 6th edition now, in the current version, there's no such thing as range of motion impairment on the cervical spine. It doesn't exist. It's AOMSI and radiculopathies for the most part. Of course, spinal fractures and disc herniation, the old standard, that stuff's still in there too. So we need to find out and determine, does the patient have AOMSI? So here's what we're going to do. There's 3 ways to determine it. There's what's called relative translation, angular difference, or linear translation. So these are the 3 mechanisms of how you determine if AOMSI is present, and they each have their own level of measurement. Relative translation is a percentage. Angular difference is degrees, 11 degrees. And linear translation is 3.5 millimeters. So you notice it's a greater sign. It's not a greater and equal. It has to be greater than those 3 numbers right there. Okay? So any one of the 3 qualifies for AOMSI. You don't have to do all 3, but you only need one of them to do it. Now, here's what's interesting. The AMA guides clearly states you must use plain radiography, digital radiography, not MRI, not video fluoroscopy, not CT scan. It has to be a regular x-ray on flexion extension because it's motion. They call it a motion study because they're in that position, and that's the only way it's going to show up unless it's a massive dislocation, of course. So the angulation method is performed, as you see on the left, and you come up with a set of degrees in comparing that segmental level to the one above and below. The next diagram is relative translation, and it's a series of measurements, and then you divide it as a ratio by the measurement of B, the vertebral body width, to come up with a percentage. This method is the preferred method for translation because the next method, linear translation, that was in the 4th edition all by itself along with angulation. And then in the 5th edition, they added the relative translation, the percentage in the 5th and in the 6th. Now in the 6th, they got rid of this one. This does not exist in the 6th edition, linear translation. Why? Because of potential magnification issues on x-ray, and they found that it's more scientifically valid to do relative translation. However, if you use the 5th edition here in Iowa, you're allowed to use any one of the 3. You can still do linear translation, this one. And the only difference between linear and this is measuring the width of the vertebral body. I went backwards. So, in the 1990s, those of us who were doing impairment ratings were taking the x-ray, doing measurements all by hand. And then I bought this fancy device that was supposed to computerize it. It still took like a half an hour to an hour. It was insanity. With software today, this is done with you putting points on the vertebrae in literally 5 minutes or less. So those measurements might scare you. You don't have to do any of the calculations. Software today does all the calculations for you. You just have to place the points on the corners of the vertebral bodies. So to wrap up the measurements there, the 20% anterior or 20% posterior on relative translation is good for the 5th or 6th. Angulation is good for the 5th or 6th edition, and it's 11 degrees, and you only do angulation on the flexion view. You don't do it on the extension view. It's only done on the flexion view only. There was also a poor article written in the early 2000s. It was published in Dynamic Chiropractic, and it stated you could add them together. You cannot add flexions measurements with extension measurements. They are independently assessed. So a person might have AOMSI on flexion only. So in your report, you'll state at the C5, C6 motion segment, the person has relative translation on flexion. And remember, you're only going to say they have it if they exceed the threshold. You're not going to do some kind of partial thing. So these are the images you're taking, flexion extension on every car accident case. You place the dots on the 4 corners of the vertebrae, and then you place additional dots on the mid-vertebral body. Now, some out there aren't doing that. They're skipping that step. But you can't do relative translation without that. You can do linear translation and angulation without the mid-vertebral body point, but you cannot do relative translation, which has been deemed the most scientific, according to the latest version of the AMA guides. You cannot do it unless you have the mid-vertebral line. So this is what we're measuring. Let's just simplify it. This is a good diagram to use in court. We're measuring how far forward did one vertebral body slip over another, or an extension, did it slide backwards? So again, this graphic can go in your report, and you're showing them how, even though you don't see the ligament on AOMSI, what is AOMSI measuring? It's measuring a motion. It's measuring a positioning of the vertebrae. How do we know a ligament is torn on AOMSI if you can't see the ligament? How do you know that? Because Punjabi and White said so. And what did they do? Every single one, 100% of all cadavers that had greater than 3.5 millimeters, greater than 11 degrees angulation, greater than 20% relative translation, 100% had a complete rupture of either the ALL or the PLL. That is why the AMA said you're entitled to an impairment rating, because 100% of the time, a grade 3 ligament tear is present. So these are how the measurements are done. This stuff is all in your notes. We've just kind of described it to you. This is a summary of everything I just said in the last 10 minutes. It gives you the threshold. It tells you which edition. It tells you which views and the unit of measurement, percentage, degree, millimeter. Question?
Well, other, like, we don't take films in our office. If you ask for this for some radiologists, will they do this? Do you have any idea?
So great question. She asked, will a radiologist do this for you, because I refer out. So if I refer out for flexion extension views and I say, hey, will you do this? A medical radiologist, unless it's a specialized musculoskeletal radiologist, probably is not going to do it unless you give them $100 or $200 extra. You know how long it takes a radiologist to do a report? 1 minute, 2 minutes tops. They're on. There's a massive radiologist shortage in the United States right now. Not doing an IME. So they're going to have all these disclaimers that say, assuming the mechanism of injury, assuming the examination, assuming the causation, all these things are there, assuming they're all there, this person, and assuming it's that MMI, this patient does qualify. So here's what they can tell you. The patient qualifies for an impairment rating with all those other assumptions. You, in your cover report, are going to say they are at MMI. The injury was caused by this accident. You have to have causation. It's a huge critical factor, causation. And then you're going to say your physical exam findings and the history and the mechanism of the injury all match up with my findings. And my findings indicated AOMSI was present. And I decided, because of the nature of this being a permanent injury, I decided to get a second opinion on the presence of AOMSI. I referred it out to Dr. X, DACBAR. They confirmed my findings. You're golden. So, again, folks, all the notes are in here telling you exactly how to do this on an x-ray yourself. But again, software takes you step by step through it yourself, and you've just put the points. Software says, put the point on the C3 anterior inferior corner of the vertebral body. Click, 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 click. You go right on down and you do it. So here's an example of that right here. So a beautiful 8-page report quoting the AMA guides, showing how the measurement was calculated, giving you a chart of the graph of the measurement. Did they meet the threshold? You add that with your DACBAR if you want to. You don't have to. You're allowed to do this yourself, but a lot of docs like to have a second opinion. And boom, there it all is. And then that creates the report. Question? Yes.
How far do you think we are from AI?
About 5 months. Yeah. You might have to put 1 point on there, but AI will do it. But here's the thing. Your name's going on it, so you have to review the points. And AI, oh, you know what, that point right there, you know, that point should probably just go just a little over here. Then you move that point. Yeah. AI's coming. AI's here. AI's already doing for the point. The problem with one group out there using AI, they're not doing the mid-vertebral body line to calculate it. They're just doing the 4 corners. And then they're calculating the average distance between, well, we all know you could have a scalloped vertebrae. Measurement's going to be wrong. So let's talk about that right now. Great segue. Landmark validity. The marks on the vertebrae. You put it on there. What if you look at this spine with all this degeneration and a big bone spur sticking out on the front? Are you going to put the point on the tip of that bone spur? So look on the left, and I purposely put it there. So this is wrong. Let's go ahead and look down at 3, 4, 5, 6. C6, the anterior inferior vertebral body point. That point is out on the very tip. Technically, you should move it back just a little bit. The AMA Guides newsletter, which is considered part of the AMA Guides, I subscribe to that too. That's another subscription. They kill you on that one. I went back all the way to 2001, and I went through every AMA Guide newsletter. And anything on the cervical spine, I printed it out. There's about 8 articles on this AOMSI determination over the last 25 years, put out by the AMA. And when they update things through the newsletter, it's considered an addition or an amendment to the books. It says so. And by the way, I've been trained by this guy, the main primary author of this book. I've gone to like 5 of his classes. So, and I've got him recorded saying chiropractors can do this and this and that. And anyway, I'm going off the rails here. My point is, these points you see here, the guides state you should extrapolate a reasonable borderline so that you're not deceived. Like, you see how those vertebrae have a little scalloping in there? And then look at the mid-vertebral line. Those are appropriate place, the ones that go through the midsection of the vertebral body. And that measurement is required. The width of the vertebral body is required to come up with relative translation. So that point, you might move it back just a little bit so it's more in line with the one above. It doesn't need to be perfectly straight down, but you're allowed to move it. Now, in court, I have never once been questioned on point placement or in a deposition. I'm not saying you wouldn't, but I've never been questioned on it. And that's why maybe the second opinion from the DAC bar confirming your findings makes some sense. So here's an example of doing an extension. So you're going to do all these points in both flexion and extension. Okay? Again, the grand total of this, I'm telling you, after you do 10 of them, it takes you 5 minutes. Can you have your staff do it? The answer is yes, as long as you review it and sign off. So if you have an RT or a highly qualified staff person who understands anatomy, they could do the preliminary findings for you to just know, hey, are they close to AOMSI? Are they at AOMSI? And then you go in and validate each of the points. But you see how fast this video is going. Once you got yourself down, you rock and roll on these things. And then if one does have AOMSI, go back, double check, triple check it. Now, let's go back to MRI and ligament injury detection. Dozens of studies have shown that MRI isn't going to show these kinds of ligament injuries that are on AOMSI. It's just not. And it's not going to be your opinion. And if some local radiologist that they get to go against you in court, you blow them out of the water because you'll have a list of a dozen studies stating it. And these are all medical studies. These aren't chiropractic studies saying these things. And you might say, Steve, where am I going to get these studies? I'm going to give you a teaser right now. And I might have somebody pass this out. But for 2 years, I've been working on a book called The Science of Whiplash. It's now 1,028 pages. It's a frickin' brick. And it'll be lovely bedtime reading for you. And it's about a half-inch thicker than this, and it's at the publisher right now. I'm going to give all of you a free book. And the reason I'm going to give you a free book, which is a $300 book, A, you got to be a member of the ICS first. Number two, you got to do me a favor, and you got to follow me on this social media stuff. My kids are making me do this social media stuff. If you see me out there, anyway, I got to do it because, and if you're not doing it, you guys have heard of all those of you who are going to be in practice 10 more years or longer, you got to do it because you won't be found. We all know the yellow pages are dead, right? That's dead. But AI is going to tell people where to go for healthcare. AI is going to tell them where to go. And if AI can't find you, you say, oh, I got a website. Hey, man, I ain't looking at that. Their algorithms are looking at your activity. So I'm doing it for my business, okay? But I got great stuff on there. Kids say it's boring. It's all academic stuff. Anyway, if you sign up, the book's going to be released in July. They'll send you an email with a one code. Each of you is going to get your own singular code, and that code can only be used one time. When you put that code in on the website, you get a free book. And then when you go online, so you're not going online now. I don't know what they're doing here, but anyway, you're going to put the address that you want the book shipped to. Okay? And it's a beautiful book, guys. It's I've got every study I'm talking about. I created all these charts. There's hundreds of research studies summarized in the book. Every category from prognosis, risk factors, positioning in the vehicle, long-term prognosis. I also have over 1,000 questions and answers for a deposition. And then after each section, I have questions and answers on what we just discussed, on how you're going to get cross-examined and grilled. I have to admit, some of these were from my own experience, some are from others, and some I asked AI, I go, hey, how would you grill me with questions to destroy my reputation? I was nervous when I'm like, oh my God, these are highly critical questions. And then we created the best answer to those questions. A lot of time went into this. I got over 1,000 hours. And because we're talking about fun facts, who was the first chiropractor to have hospital privileges, admitting privileges to a hospital in the state of Iowa? Anybody got an idea? Got any Carroll County people? Say it. Bob Vanami. Winner, winner, chicken dinner. You get 2 books. Okay. Bob Vanami, Manning, Iowa, in the 1980s, got hospital privileges. Why did I put that in there? Because Bob was supposed to be in the damn class, and I wanted to say something. He's in the other class. Okay. So let's talk about chronicity. So these are the studies that Arthur Croft has in his book. So we all know who Arthur Croft is. He's the godfather of whiplash. He is the godfather. There is no other human being who has done more research than Arthur Croft. These 2 books here. And then he did one on mild traumatic brain injuries in early 2000s. The problem is Arthur has retired. He's a PhD, DC, MPH, accident reconstructionist. He's got every degree under the book, published tons of studies. And these are just a select few of his studies. I have all those and more in my book. And then we've added these. Since 2001, there's a ton of other studies that back up what Arthur Croft has been saying all these years. And all these new studies, some of these studies are as recent as, it says 2023. I got another one from 2025 that's not in my slide presentation, that's in the book. Tons of updated studies. It's incredible the amount. So this is the book that you'll all get if you follow me, say you like me, that kind of stuff. So biomechanical and crash dynamic factors. Well, patient-related and clinical prognostic factors. If you're over the age of 50, that's going to make your results worse. If you had pre-existing spondylosis, facet arthrosis, it's going to make it worse. If you had osteoporosis, your prognosis is worse. If you have a cervical lordosis, it's going to make it worse. Radicular symptoms, you automatically have a worse outcome. All this is documented by the study. This is an actual real scar tissue formation in collagen fibers, microscopic level. I had to pay $120 for that picture. And then my fake picture that chat did for me is scar tissue. These are effective in the courtroom. Okay, these are effective. Then denervation supersensitivity. I first heard about denervation supersensitivity about 30 years ago from Dan Murphy at one of his seminars. And the amount of research on denervation supersensitivity, and the research studies often call it hypersensitivity. Unbelievable what's happened in the last 10 years. Tons of it. And it leads to a long-term prognosis and why patients have this ongoing mild achy pain. It's been researched upside down. So you have to be able to talk about it. And it's because of scar tissue and then the microscopic nerve endings around the border of that scar tissue, leading to chronic pain or central hyperexcitability. I got to tell you, folks, I had no idea the amount of research that's out there besides what Arthur Croft gave us and his research. Since his books came out, it's exploded, and it's all by PhDs. Most of it is non-DCs. The good thing, I have one whole chapter in the book that shows chiropractic care treating whiplash injuries. There's 4 major studies on that we get high ratings, that were very effective. So if you get quizzed by an attorney saying, well, wait a minute, you've got AOMSI, isn't that laxity? Isn't that hypermobility? You're adjusting it, you're introducing motion. Well, I'm introducing motion on the segment below, because we also know adjacent segment degeneration is researched at the yin-yang as well, showing that the level below is going to start getting degenerative changes in osteoarthritis. It's a fact, it's going to happen. The study showed, the one study was 82%. 82% of the people within 7 years post-injury of the involved level were getting degenerative changes. Not from aging, from the injury. Now, in an impairment rating, are you allowed to apply an impairment rating to a future predictive problem? Even though you've got all these mounds of scientific studies showing you that the person is going to have degeneration, have an 80+% chance they're going to get it, are you allowed to give an impairment rating on future? The answer is no. You can only assess an impairment rating on what is present in front of you today. Number 1 ligament injured in whiplash, the facet capsule. Now, can a facet capsule damage contribute to AOMSI? It certainly can, and it most likely does. If there was enough force to tear an ALL or a PLL, I guarantee you the facet capsule has some kind of damage. I'm not saying it's a grade 3, but it has some kind of damage going on. And if it's got damage going on, then all of the neurons, all of the nerve sensitivity on that facet capsule for motion is certainly affected, chronically irritated from the overstretching, and especially if a prognostic indicator such as head rotation at the time of impact or a lateral is going to cause what? The right facet is clearly going to get torn. Side impact, head goes this way. And if the rebound is great enough, they may get it back on this side too. If you haven't seen videos of whiplash injury in the degree, I just had a former patient of mine, his son got in a car accident and he wanted my whatever. All these kids today, they got these cameras on their, stuck to their windshield and stuff. They got these cameras. He got rear-ended and it was only like 20 miles an hour. And just so you know, speaking of how many miles an hour, how many miles an hour does a rear impact need to be to create a tear? Pretty good. One study did show 5. The majority of the studies agree 6.8 miles per hour is enough to cause ligament damage. It's a fender bender in the parking lot with no fender damage. So I shouldn't have said fender bender, fender collision. So back to the kids in the car. They had the camera on there. They were unsuspecting, they're going along, they're slowing down on the interstate because all the cars in front of them were slowing down too, but just didn't judge it good enough. Rear-ended them. Should have seen everything fly and their body flying back and forth, 20 miles an hour. You can see why tearing occurs. Let's go over another risk factor. If you're about to be rear-ended, should you be all relaxed like a noodle, or should you slam your both feet on the brake, hold the steering wheel firmly, and look straight ahead? The latter. Unsuspecting injuries are worse for your prognosis. If you're all relaxed like a noodle, the head's flying farther and the ligaments tearing more. So there are other ligament injuries. We're not going to get into it today, but the top 3, facet capsule, followed by the ALL or PLL. Question?
And it's really the impact of acceleration and deceleration and the amount of ramping that happens to the body.
And you said the right word, ramping. And just because of time, I'm not getting into crash biomechanics, but I do have a whole chapter on that too. But yeah.
So can you talk a little bit about, certainly we talked quite a bit about the spine, but about thoracic outlet syndrome.
So,
Often related to seat zones.
yeah. Thanks for bringing that up. So I am in a couple slides here. Radiculopathies. Yep. So we all know we've got the phases of healing. We've got inflammation, we've got repair, we've got remodeling. Then according to Arthur Croft, he graded injuries with 5 different grades: minimal, slight, moderate, moderate to severe, and severe. And he categorizes it. It's important you categorize the injury. And I hate it when chiropractic, it's a severe injury. Stop using the word severe if they don't have AOMSI. Okay? Or other rateable findings, because it's not severe if they don't have a rateable finding. It's moderate to severe, but it's not severe.
Did Kraus standardize cervical, thoracic, and lumbar, or is this only cervical?
So this is cervical spine.
Okay.
Yeah.
Did he standardize the other ones, or is this applicable?
I have not seen that, no. Now, I will share with you, this can be applied to any region of the spine, though. You know, even though his book is focused on cervical acceleration, deceleration, you notice when you look at his terms and descriptors, it's really spinal, but all the research that is out there that I'm going to tell you, there is a lot of research on lumbar spine, but the majority of the research is all cervical spine.
Isn't it usually the knees and lower back happens during the deceleration phase?
The what?
During the deceleration phase, where
And then the knees hitting the dashboard.
the dashboard and impacting the lower
So
back area.
if we were to address all of the radiculopathies, all of the brain injuries, all of the extremity injuries, the wrist injuries, we would need more books than all of this. You can only do so much. I'm at 1,028 pages, and I'm on the cervical spine. Ron.
Just a question, do you ever recommend in your documentation differentiating between the severity of the pain versus the severity of the injury?
That's a great point. So the question was, do you ever document in your records severity of pain versus severity of injury? It is 2 different things. So when someone gives you a 9 or a 10, pain is severe. The injury may not be severe. It may be, it may not be. So here's the gold standard that Croft brings up. And someone asked about the Quebec Task Force. I have a half a chapter dedicated on Quebec Task Force and Croft and comparing them side by side. And there's been 3 different research studies analyzing them and the weaknesses with the Quebec Task Force. Quebec Task Force is good for acute injuries. And I'm going to leave it at that. Croft addresses the full continuum, acute through long-term chronic permanency. Now, there's been a lot of discussion, even in the prior room here, what's the right number of visits? Croft based it on over 2,000 insurance claims, so whiplash injuries only, filed to insurance companies and their database that he got access to. In addition to that, he did surveys of chiropractors throughout the country because he was lecturing during that time a whole lot. And this is how he arrived at these numbers as a standard of care. Now, it doesn't mean a patient should be prescribed 56 weeks of 70 adjustments. It means that's not the prescription, it's what was used, okay? There's a big difference in what you recommend to a patient. So any chiropractor says, Betty, you know, I've classified your injury as moderate to severe. I'll take an easier one. I was moderate. You're going to need about 76 visits. You're not doing that, okay? What he's saying is by the time the case resolved and plateaued, those were the numbers. By the time they reached MMI, maximum medical improvement. I have a lot of research backing that up. It's quite interesting. Now this is a kick-ass document. And the reason it's kick-ass is because I created it. Okay. This document takes Kraus guidelines, it takes the AMA guidelines, it takes 18 research studies, a lot of them current, fuses it all together. So I didn't make any of this up. I didn't do a research study. I took everybody else's research and plugged it in. So you'll see we've got the thresholds, which determine the severe one for AOMSI. That's AMA, that's the guides. I kept it to the same 5 severity levels that Croft did. And then in the middle, do you know how many studies are out there on sub-threshold injuries? Can you go in and say, let's say you do an AOMSI analysis, and the AOMSI analysis says, hey, this person has a 2.5 millimeter linear translation. Can you say and use that in court? You darn right you can use that in court. Because the studies show that there is ligament damage. There might not be a full tear. There's nerve damage. There's potentially radiculopathy. The studies show that all of that is present. And I created, have you guys heard of the Daubert analysis when you admit something in court? Well, I've involved attorneys and others. I have a full 5-page Daubert analysis on this and all the studies for admissibility into court. And again, all that's in the book that you're all going to get for free. My point is, you can use sub-threshold findings to say there's an injury. It's just not bad enough to qualify for a permanent impairment. And there's different layers of it. I got a 10-minute flash sign here, so I have to rock. All these slides are available to you from the ICS. I've submitted them to the ICS. One of the key things we wanted to go over is a narrative report. What all needs to be in your narrative report? Well, when you do the impairment report, that's considered a supplemental report. And when you do the impairment report, you have to make sure you state you considered the physical examination, you considered relevant clinical studies, and the specific individual elements, which is the history, which is the mechanism of the injury. You've included all of that. So the history has patient outcome reported measures. You have to be doing PROMs and OATs, okay? The visual analog scale. The AMA guides even lists certain ones that they thought were the best. I found a few meta-analysis studies, and they listed the best psychosocial ones. So I put all that in there in these slides for you and in the book on what are the best outcome assessment tools to be using. It's really a requirement that you use something before you would give an impairment rating. Some of these obvious ones, the FRI, the Functional Rating Index, the Roland Morris on the cervical spine, there's a whole bunch that have been around forever. But there's some new ones on there that you can use too. So the 5th edition is generous. We talked about you could give a 25 to 28% impairment rating if AOMSI was present. And it's just that simple. If you use the 6th edition, that same finding by itself is 4%. Big difference. Here's why there's a difference. The AMA guides bundled, the 5th edition bundled radiculopathy, disc, fracture, AOMSI, all kind of into one box. And if any one was present, so what they did in the 6th is they broke it apart. And when I say 6, I'm referring to the new 2024 edition. So AOMSI by itself, with nothing else considered, is 4%. And as we said before, AOMSI is a diagnosis. So you can use that as a diagnosis. So radiculopathy, thoracic outlet syndrome, they give a considerable impairment rating for those things, anywhere from 4% to 17% for a radiculopathy. And then we would use the combined values chart to, when I say add them together, we combine them. So here's a quick example. C5, automatically a 5% if you have an MRI demonstrating a C5 nerve root injury or lesion, or you have an electrodiagnostic finding, or you have Sperling's test. Sperling's test by itself. And of course, the description. You can give a 5%. So now you can combine 4% and 5%. So we would go 5% up the vertical, 4% over. I think that comes to 8%. Here's an example of a 14% one. And when you go down the book, it says now you got to have 4 of the following. So if 4 of the things in that blue box are present, they get a 14% impairment rating just for the radiculopathy. And then you would add the AOMSI. So radiculopathy is weighted very heavily in the AMA 6th edition. So in your report, you're going to have an impression, and you're going to use simple language. And these are in your slides. So you can use the language I have in your slides for your own narrative reports on what you're going to say. So this is what a front cover page would look like from a DAC bar or a medical radiologist doing an AOMSI report. They're going to give you a one-pager followed. Before I go into that, there's some stuff in here that the DAC bar is giving as a disclaimer. The DAC bar is saying, hey, the exam, the history of the injury, all of those things, and MMI. Then they're going to give the discussion of the findings, of the measurements, and then their final impression. And they will say the patient is eligible for an impairment rating. They're not going to give you the impairment rating. They're going to say they're eligible for a 25% impairment rating. And then these subsequent pages that you see list the images, it lists the findings, it explains how the finding was discovered, how it was measured, so that an attorney or a judge or a jury can see how it was measured. You got to give them the information. And then you might even have a graph in there that shows them how far away from normal it is, and it evaluates each single motion segment. And then it's good to put some of these images in there. So let's get to one key thing, the references. If you want to admit the scientific literature, you want to include the references with your report. All 24 of these references, I go over the studies in great detail. But in addition to these 24, there's 150 other ones that are kick-ass too. And you might decide to include them in your report. And when you do, list the reference at the end of your regular report so you can admit it into evidence. But if you're going to do that, make sure you don't just do the abstract. Make sure you know what's in that whole study. I've been deposed before, and I've seen the guy show up, the opposing attorney, with the full study. And then he highlights one line of that study that might not be that great, but he's taking things out of context. So you got to know it, and don't let him just show you and walk away with it. I'd like a copy of that, please. And before I respond, I'd like to read the whole study. I apologize to the jury that it's going to take 15 minutes, but I need to read the whole study. I'm not going to judge a study, and certainly can't expect me to have memorized the hundreds of pieces of literature out there. So don't let that attorney push you around. So the impairment report is a supplemental report, but the narrative report has to contain discussion about the prognosis, because your impairment report isn't talking about prognosis. You're just saying they're impaired, period. Your narrative report's going to give the final thing, and these are all the elements of a narrative report. And some of you might like, Steve, this is going to take 2 hours to create this report. I know. It's a lot. But you charge for it. I bill for these reports. $490 for the one report, $500 for another. Then attorneys, they might not ask you for a report for a while, and they're only going to do it on the ones that they know are going to court. Otherwise, you might keep it simple. And you need to make them aware of that. So if you're going to court, I want to do a full narrative report. Why? So that you can read from your own report when you're sitting on the stand or in a deposition. You got all your stuff in front of you. It's all in the report. So you don't have to go thumbing through your notes. And again, we talked earlier, I've got all the best questionnaires. The AMA Guides even gives you a one-pager for an impairment rating report. They have a sample and you fill in the blank. And that's if you're doing range of motion. You can fill that out. So in the end, you're telling a story. You're using your narrative report to tell the story of what happened, why they responded to care to a certain point, but they have a permanent injury. You have scientific literature to back it up, why the prognosis stalled, and why they have an impairment rating, and that's backed up by the AMA Guides, resulting in an impairment rating. So massive shortage. Do you know in North Carolina, imaging centers getting their reports out are waiting 2 weeks because the radiologist is so backed up? So to answer your question, the answer still is yes, because there are some DAC bars who do provide this service. And again, I gave a disclaimer, I don't know if you're in the room. I own a company called Telerad, and we have a group of DAC bars who will do that for you. So you do a service, you submit it, they'll do the report for you, the measurement, and they'll spit it out. Now, let's say you did that. Here's my advice to you. Do you know you can bill $400 for that report? There's a code for it. I have it at the end of the slides. You can bill $400, you can bill $295. I'm not telling you what to bill. I'm just going to tell you of hundreds of doctors around the country doing this. Some bill $295, some $395, some $495. Now, if you're going to bill for the report, you can't bill for a radiologist's report. Now, you might pay the radiologist to go do that. My advice to you is you do the analysis yourself, and if it comes out that there is an AOMSI present, refer it out for a second opinion. They'll go do it, they'll confirm it, and then you have a cover sheet, a report, because the radiologist is going to put disclaimers on the report. They have to, because they've never seen the patient. So they're not doing an independent medical evaluation, because when you do an IME, you have to see the patient for the IME.